nicht der Christian, den ich heute brauche als Unterstützung.
Achso. Guten Morgen, Albin. Aha.
Morgen, hallo. Guten Morgen.
Max, ich denke, wir sollten irgendwann zwischendurch mal ein kurzes Gruppenfoto machen.
Ja, wäre schön.
Und dann denke ich, sollten wir auch anfangen, oder? 43 Teilnehmer, das ist prima. Wie schaut's aus bei dir, Max?
Von mir aus jederzeit.
Good. So, dear all, so I think we are right now with more than 40 participants in this e-conference, and I would like to welcome you all for this very short announced, but very well participated e-conference of the German Society of Lasermedizin, Deutsche Gesellschaft für Biophotonik and Laser in der Medizin. My name is Ronald Sroa. I am the General of the DGLM for everybody. And yes, I also, first of all, I would like to thank Max Aumüller for his efforts to make this conference possible, to share the information about this conference and make all this advertising and all the... So today we have the annual Next Generation Conference. And this is called Next Generation because I, by myself, I am an old guy and I'm a long-term survivor of this German society. And so we really want to push the next generation into scientific communication, especially in this Central Europe part named DACH, so Germany, Austria, Liechtenstein, and Switzerland. And so we want to combine all this. When I was starting in laser medicine, roughly more than 20, 40 years ago, it was nearby this time at the foundation of the German Society. And that was in 1981. And at that time, only the German Society exists. And I feel very proud when I was attending the first parts of this of the conferences, which was generated by the German Society at that time. And at that time, there were only roughly more 200 to 300 researchers who are working in this field with medical application or with regard to medical translation. And meanwhile, the situation completely changed because we have a diversity of technology which can be used clinically, and there is a rich variety of technology developed during the last 40 years. And also not only medicine by its own. At that time when we started, the translation was directly into the medical hospital. Nowadays, we have to think about medical devices in laboratory medicine or biophotonics in pathology, so in microscopy. And there is a whole branch of different technologies developed over the year. So the first aims of the German society changed completely. At that time, that was the main aim was the establishing of national laser centers. That was a driving force for the medical technology at that time. And at that time, so in Munich, we started with a laser center, and also in Lübeck, the laser center started, and also in Berlin, the laser center started, and several other centers started in Germany, and they want to connect each other with the aim to translate knowledge into clinical applications. So it was always a combination between physicians and physicists. And the main communication, or one of the communication, were congresses. And with this regard, the Laser Munich starts somehow in the 80s or 90s century. And that was the base of the well-known World of Photonics Congress and Exhibition. And the DGLM started at that time to combine science, exhibition, and also the translation. That was the base. Meanwhile, other charities like the OSA and the SPIE from the US and so on, they come in and joined this World of Photonics Congress. And yes, it grows a lot, but it also separated the DGLM from this part because it was too expensive for us. So the DGLM also started with several charity journals, as I can show here nearby, different journals. Unfortunately, all these journals failed to get journal impact factors, which became more and more interest in all our scientific work. Nowadays, we have a new journal. I come up to this later. So, and finally, during the last years, also the tool laser and optics is more or less established in several medical disciplines. In this way, the scientific discussion between translation and the discussion between physicians and the applicators and the physicists and basic researchers who develop all these things and tools changed a bit, and it is more located. So the competence of the DGLM more or less is from the very beginning the translation and the education. And in education, we mean also the training for laser and biophotonics applications in the medical environment. This is for the physicians on one hand side. We make laser courses, laser safety courses, and also on the physicist side when we think about the physicists. Because in traditional medical physics, where we learn about, or the students learn about NMR and CT and X-ray and so on, light is not really established. And therefore, we switch in and we fill the gap of this light, and the photons between 100 nanometers and roughly 20,000 nanometers. And unfortunately, or it's luckily, lasers and light is also a translational competence between all, or a discipline between all different parts. It can be used in every medical discipline, more or less. The competence of the DGLM is also translation activities. This is in the in education direction. This is the NKML. This is the university profile, where the medical doctors are educated. We can also work in Leitlinien, so guidance, consulted by the Gemeinsame Bundesausschuss, a huge community, which is also combined with the Gemeinsame Bundesausschuss, with roughly one.
So somehow the Zoom got.
And therefore, in 2020, we established an electronic conference.
So we are back online
in May and in June, where all institutes and working groups in this laser medical fields were sitting on board. One is translation, another is education, a third one is outreach, and the last one is the next generation. In the translation part, we are working with the AWMF. We try to combine our activities with the politics, with the economy, and in direction of grants. We are also talking about the medical device regulations and also about medical guidance, medical guidelines, and so on. And also we try to combine competencies of all these institutes together. From the education part, we make this and we offer the laser safety certification courses, and also we try to establish more and more the biophotonics field in the universities. The outreach board is created to combine and to give all these informations to our peoples and to all our members. So it is a central part for networking. It creates our websites and maps. So the websites has to be improved. And also this kind of e-meetings and summer school, and also the congresses we want to perform. And last but not least, the next generation was founded 2 years ago by a couple of students as a part of the DGLM to motivate young scientists to be part of this nice DGLM charity, to combine your knowledge and to focus your to improve your networking capabilities, not only sitting in your own lab or in your own institute, thinking a little bit beyond your horizon and connect each other, and potentially aiming into friends. And all second president of the German Society of Laser Medicine and Biophotonics. Carsten Phillips is the president of the German Society of Laser Medicine and Biophotonics, and me. And the fourth one, which I haven't mentioned so far, which is in the one of the heads of the German Society, is Adrian Rühm. He is for the members. Okay, with this, I would like to end with this introduction of the DGLM. And I'm very lucky that today we have 19 presentations from all countries of the DACH region. And I feel very fine that you join us. And as we also want to translate some skills. I'm also happy that Herbert Stepp give a skill presentation about how to write papers. And with this, I want to hand over to Max because he is guiding through the whole day. Yes, I hope that all of you give nice presentations. All of you will have the possibility to give questions and comments to each presentation. And during the breaks and also during the discussion part, come together, discuss not only about scientific rules, but also discuss about where you are you sitting, how is about your lab, and so on, what are you doing. So improve your discussions together. So thank you very much. With this, I will end up, and Max, you're the time right now.
Thank you very much, Ronald, for the introduction of the DGLM. Before we start with the seminar, I want to introduce to you short the DGLM next generation. I hope there is it. So with this short few slides, I want to show you just who we are from the DGLM next generation and what do we want to manage with this group. So the DGLM next generation, well, we founded it with 3 persons in 2020, so Stefan Strobel, Christian Heckel, and me. And unfortunately, Stefan and Christian couldn't join today because they have finished their PhD work here and are now working in the industry, so they are in the company and couldn't get the break for watching us today. And when we founded this, well, we thought, okay, also of student chapters, so maybe you know they are from OSA and from SPIE, they are so-called student chapters where students can get together and accomplish money for doing seminars and conferences or going on a trip. And well, we wanted to do the same and found the same, but with not international, but with students from Germany, so that we learn and get known other students in laser medicine and biophotonics from German institutions, and just to get known to them and their work and to show our work to them. And in the end, our target is we want to build up a network for young scientists, so not only PhD students and master students working in the departments, but also young postdocs have started their career in research, or people started working in industry, and medical doctors working in the field of laser medicine, which have just finished their studies or which have started working in Germany at the hospital. And with bringing all these people together, we want to help them in assistance and support them in scientific and social aspects they have during their work. And this we want to do so that we have meetings with these people so that we can get together maybe in other conferences. So if hopefully Corona is over, we can meet in person after a conference, so that we make a social event by the next generation, or we do virtual events. And at these events we can meet with people, share our experiences and ideas on possible works, or that some institutions can work together on a project. We can help each other so that the experienced members of the next generation can give some advice for the younger people with their experiences, and we can share manuals on software. So if someone is using a new software and he doesn't know how to do it, maybe another person of our group knows it already and can help with it. And I want so thanks again to the people from the EPRT for this. So I think every one of you received this flyer on the next generation, and hopefully some of you want to join our group after the seminar so that we can build it more up, because still we are only few people in this group, and when you join us you can also participate in this building process and also show your opinion how you want to establish such a group, because we want to build a group from students for students, or from young scientists for young scientists, so that you can actively participate in how this group will be in the future. And if you have any questions on the next generation, or if you want to join us, you can use the button on the flyer or just contact me or other people from the DGLM Presidium, so Ronald or Adrian, and then they will guide you how you can get a member of us. And with this, I want all of you again to welcome from the seminar. Thank you everybody who helped in organizing, and I hope we have the next hours a great time together and listening to the talks. So, thank you very much. Now let's have a look that I don't mix something up. Okay, so I think we can already start with the first talk. I scheduled it for 9:30, but if we can start a little earlier, you can all get a few more minutes, maybe in your weekend. So our first talk will be by Abhay Setia from the Department of Vascular Surgery in Schwäbisch Hall in Baden-Württemberg, and he will talk about the midterm, so 36-month safety and efficiency of endovenous laser ablation with a 1940 nanometer laser and radial emitting fibers, and compares with to 1470 nanometers. So we will have at the beginning an insight into a clinical application of laser medicine. Before we maybe, if you have any questions, just raise your hand or write it in the chat so we can read it out in the end. So, Abhay, the stage is yours.
All right. Thank you so much. Good morning, everyone. I would like to begin with a word of thanks for the whole DGLM team for this platform, for this online conference, and for giving me the opportunity to present our clinical results, the midterm results of our experience with the new 1940 nanometer laser for the treatment of varicose veins. The treatment...
I'm sorry to interrupt you, but I don't know if it's for everybody, but in my screen, I only see half of your slides.
Oh, okay.
Maybe just Ronald or can just tell me if it's all for everybody or only at my screen.
Oh, it's also on my screen.
It's also on my screen too.
Okay. I'm sorry.
Maybe
I'm
you
just
can
gonna
stop and restart screen sharing.
Yeah. Okay. Stop. So I am not sure how this thing.
It was just when you make the presentation mode.
So is it better now?
Better.
Yeah, now it's good.
All right. Okay. All right. So yeah, I'm gonna start from right here then. So yeah, the treatment of varicose veins has come a long way since the stripping procedure described by Sir Babcock in the past decades. The desire and the passion and never dying craving to decrease the invasiveness of varicose vein treatment led to the development of endovenous thermal procedures like radiofrequency obliteration and the endovenous laser therapy. And these procedures work on the principles of vein obliteration and reflux elimination without the need of operative crossectomy or stripping. Now, there are an array of fibers and wavelengths that are available for EVLA. And until 2019, the most commonly used laser systems had a wavelength between 800 and 980 nanometer. And the recent trend towards using a longer wavelength with radial fiber is supported by numerous experimental and clinical studies and randomized control trials comparing the hemoglobin targeting or the shorter wavelength to the water targeting or the longer wavelength laser systems. The longer wavelength laser systems like 1470 nanometer and especially 1940 nanometer are relatively new and exhibit superior patient's comfort with lower pain levels, lower hematome incidences, better risk profile, and if not better, but the same occlusion rates as well. So based on the results of these exhaustive studies, the German S2K guidelines recommend that longer wavelengths with radial fibers should be used for EVLA. And EVLA is based on the principle of heat transfer to the vein wall in the form of photons or laser energy, which in turn is absorbed by tissue chromophores like water or hemoglobin. The longer wavelengths have a higher coefficient of absorption in water, which targets the water molecules in vein walls. So this selective optical penetration leads to decreased damage to the perivenous tissue or structures, which leads to diminished complication rate. And as you can see here, 1940 nanometer possesses even a greater coefficient of absorption in water than 1470 nanometer. And keeping these physical principles in mind, we were undoubtedly convinced for its clinical application and evaluation. And after experimental evaluation, this innovative laser wavelength was applied in a clinical setting to evaluate the short and the midterm safety, efficacy, and effects on patients' comfort of this new wavelength. Between June 2013 and December 2014, 177 consecutive EVLA procedures were carried out in 139 patients in our medical center hospital in Schwäbisch Hall. Because this was a non-randomized trial, the results were compared to the currently available literature for EVLA using 1470 nanometer laser and radial fiber as a benchmark. Patients with recurrent varicose veins, past history or current DVT or thrombophlebitis and diameters of more than 15 millimeter were excluded, and the pre and intraoperative details of the patients were recorded on a homemade protocol, and the vein diameters were measured at various predefined points during duplex ultrasounds. Regular follow-up visits with clinical and duplex ultrasound examination were planned within 1 week, 1 month, 6 months, 12 months, and yearly thereafter for up to 10 years. Based on our comprehensive clinical and experimental experience with EVLA using radial fiber and assumption that shorter stump length could mean low reoccurrence, we carefully placed the fiber at the saphenofemoral or the saphenopopliteal junction at the distal ostial point, or P2, as depicted in this diagram and as shown by an intraoperative ultrasound to your right. Now, the parameters were set for evaluation of the procedure. These were non-occlusion distance, non-occlusion recanalization, and the patient's comfort was evaluated by following factors. Now, additionally, the results were color-coded for ease of understanding, And green or category 1 were asymptomatic patients with appropriate occlusion of the treated vein. These patients depicted no recanalizations and no reflux in the accessory veins. And category 3 or red were EVLA failures. These were either symptomatic or asymptomatic, and the recanalizations occurred in these patients in the veins that were previously occluded. Now, coming to the comparison on the literature obtaining for our review, this was carried out in February 2021 and revealed 3 studies composing of 616 EVLA procedures and 576 patients. All the patients in our study were examined within 1 month of the operation, and follow-up rate at 12 months was 72.8%, and at 24 months 85%, and at 36 months 40 limbs were examined respectively. The occlusion rates at 12 months was 98.5%, and reflux in the accessory veins was observed in approximately 5% of patients, and 3.5% of patients showed recanalizations. Coming up to the duplex ultrasound results, we achieved a very short stump length at the end of our follow-up period. That was 1 centimeter for the great saphenous vein and 0.3 centimeter for the short saphenous vein. Now, minimal to few post-operative complications like ecchymosis, skin discoloration, and EHIT were observed. Post-operative pain intensity was low and was 1.3. The incidence of persistent laser-induced paresthesia reduced over time to only 2.2% in the long-term or the mid-term follow-up period. There was a significant improvement in the VCSS scores. Now, as I mentioned earlier, we measured the diameter of the truncal vein at various points, and this revealed a very interesting finding that the diameters of the ablated vein reduced significantly over time, and various segments of the vein could also not be recognized on the post-operative duplex ultrasound examinations. As I mentioned before, our results were compared to the literature data of patients treated with 1470 laser and radial fiber, which was used as a benchmark. And this present study was comparable to the literature in terms of study type and EVLA procedures. The few differences were, for example, in one study, only the great saphenous vein was treated, and selective procedures or adjunct procedures were performed very selectively in the literature cohort, and we performed phlebectomies in all the patients. The catheter, as I showed before, was placed at the saphenofemoral and the saphenopopliteal junction, and the pullback was continuous with a maximum velocity of 1 millimeter per second. And with this above mentioned protocol, as you can see here, we achieved the same results with definitely lower lead for cumulative for both the great saphenous and the small saphenous vein, and individually for both the veins as well. The complications like bruising, discoloration, skin burns were lower, and the rate of persistent paresthesia and recanalization was comparable as well. Because of concomitant phlebectomies performed in all our patients, reflux in the accessory veins and redo operations were significantly lower. Now, there were certain limitations to this study. This is, of course, not a randomized control trial, and the test of significance was not possible for all the parameters, and the follow-up rate at 36 months is low. Nevertheless, this is one of the pioneer studies which shows the clinical application of 1940 nanometer laser. And to summarize, I would say EVLA with 1940 nanometer laser and radial fiber is definitely safe and effective for the treatment of varicose veins, and the lower lead requirements make this even more attractive. This newer wavelength offers lower complication rates and reduced complication rates with reduced postoperative pain levels as compared to 1470 nanometer. The occlusion rates are comparable, and shorter stump length and concomitant phlebectomies account for the lower redo operation rates. But of course, head-to-head comparison in terms of a randomized controlled trial has to take place between 1470 and 1940 nanometer before we can say which one is better and which one is not. With this, I would like to conclude my presentation. I thank you all for your attention, and if you have any questions, I would be more than glad to answer them.
Thank you very much for your talk, Setia. So,
Gladly.
1940 laser seems to be a promising tool for EVLA use.
Yes, it does indeed. It is definitely promising, and it could be the future of EVLA. But as I said, it is too early to make any conclusions, any concrete conclusions regarding its clinical application. But what I can definitely say, it is feasible, it is safe, it is effective, and it can definitely be offered as a treatment modality to our patients. And as you can see, the patients had reduced postoperative pain, reduced incidence of postoperative complications, local complications, and there's a definite need to study this new laser wavelength more.
Yeah, do we have questions from the audience to apply for?
Yes, I would have a question.
Yes, Carsten.
Thank you, Mr. Setia, for this nice presentation and the comparison between the two wavelengths. You mentioned you do the procedure of a phlebectomy additionally in all patients. What exactly do you mean by this phlebectomy? Is it a cross ligature or crossectomy, or a minor surgery added to the intraluminal procedure? Is it right? Did I get this right?
Sure. Thank you so much for your comments and your question. So we did not perform crossectomy or stripping in any of the patients. This phlebectomy means the side veins or the accessory veins were treated with mini incisions and were, let's say, removed with these phlebectomies.
Okay.
Yeah.
I understand. So you prevent the accessory veins to develop to larger veins in the future.
Yes,
yeah,
definitely.
I understand. Thank you.
No
That's
problem.
a good concept.
Do we have further questions? See no hand.
Well, if there's not, I have experience with the bare fiber application in venous malformations, and what we always see is the carbonized tip of the bare fiber, and I wonder if there is any damage to those ring mode applicators or those lateral distributing.
And to be very frank, we did not notice any damage to any of the fibers used in any of the patients. That is the first thing, but definitely we observed carbonizations in a few cases. Because this was the initial phase of our application, we did not document the grades of carbonization. But nowadays, we have developed a grading system, like our own grading system for carbonization that we can see intraoperatively, and we grade them accordingly.
This carbonization may be related, well, you do success rate of the bare fiber is accomplished with this carbonization part of the fiber, and maybe because of damaging the vessel wall directly in contact with the fiber. That's my opinion. And this is prevented with the radial fiber.
High power density at the end of the tip. Here you have this ring, and therefore you have a reduction of the power density on the ring. This is on one side. So, and due to the wavelengths of 1940, you have really reduced absorption by the hemoglobin, more by the water. And if you're working more in this visual spectral range, then you have the absorptions by the hemoglobin, and this makes this carbonization.
Okay. Thank you.
Okay, thank you for your
Thank you so much.
comments, Carsten and Ronald, and thank you again, Abai, for your talk on this interesting application. And let's go on with the next speaker, who is Eric Seifert from the Medical Laser Center in Lübeck, and he will show us a medical application of the ophthalmology. And his title is The Cell Damage Prediction to Improve the Retinal Laser Therapy.
Yeah, thank you very much.